Hello everyone, this is Dr. Sultan Moinuddin Shaukat Ali, MBBS, MD and DNB in radio diagnosis from State GSMC and KEM Hospital, Mumbai. A faculty in Ikramat Academy. Today we are going to start the third session of ultrasound features of malignant thyroid lesions. Okay? So without any delay, we'll begin it. A brief overview of how we are going to go about in this session. So in my last session, we talked about follicular CA, that is ultrasound features of follicular neoplasms, and we have also discussed about ultrasound features of papillary neoplasms. So in this session, we'll be talking more about the remaining neoplasm, that is malignant lesions. So I'll be talking on anaplastic, medullary, and lymphoma. Okay, so let us start with the sessions. So brief outline so that the concepts are clean. We know that there are 5 important thyroid malignancies. One is follicular CA. I told you that what is the risk factor? MNG or previous adenoma for follicular CA. Second is papillary CA. What is the risk factor for papillary CA? Radiation, and this can also be familial in case of. Third is medullary CA. Fourth is anaplastic CA. And fifth is lymphoma. So we have talked about follicular and papillary CA in our previous session. Now in this, we'll dedicate ourselves to learn medullary thyroid CA. Okay? Now, what is the difference, major difference in cell of origin when you compare this with follicular carcinoma of thyroid? A major difference is that medullary carcinoma of thyroid develops from, very important, parafollicular C cells. So interstitial cells, which are also called parafollicular cells or C cells, this is where medullary CA arises from. Now, what is the normal function of C cell? It is release of calcitonin. So as a result, in this in this tumor, calcitonin is a tumor marker. So serum calcitonin is raised in patient with medullary carcinoma of thyroid. Now again, a very important feature is that it is hypoechoic. This is same like papillary carcinoma of thyroid. Even papillary CA is hypoechoic. Now medullary carcinoma of thyroid also has got multiple microcalcifications. This is feature which is similar to papillary carcinoma of thyroid. Another very important feature, very vascular. Again, this is similar to papillary CA. This can also show nodal metastasis. So all these 4 features are similar to that of papillary carcinoma of thyroid. But a very important feature which makes it different is that it is associated with MEN. What is MEN? Multiple endocrine neoplasms 2. So this is associated with MEN2 syndrome. So whenever you have that on FNA, it turns out to be medullary carcinoma of thyroid, you should look for other neoplasms of MEN syndrome like pituitary adenoma, pancreatic malignancy, pancreatic neuroendocrine tumor, then pheochromocytoma. This can be associated if this patient has got MEN2 syndrome. Okay? Now, a very important another difference between papillary CA and medullary CA is that one is cell of origin, second is this can be multifocal. What do you mean by multifocal? If this is a thyroid gland, then you can have multiple lesions of medullary carcinoma of thyroid. So it can be multifocal. Second important finding is that although it shows microcalcification, sometimes it can also show macrocalcification within it. Okay. So these are 2 important features which are only seen, and association with MEN2. Okay, these are features of medullary carcinoma of thyroid. A tumor marker which is must you have to remember is serum calcitonin levels. Okay. Now with this, let us come to the image findings on ultrasound. So here, if you see image 1, you are able to see this is the thyroid gland, and within the thyroid gland you are able to say this hypoechoic, very hypoechoic, right? Very hypoechoic lesion, which is solid. So this is, and on vascularity, can you see that there is increased vascularity. So increased vascularity, solid, very hypoechoic lesion, and you are able to see multiple foci. So in this, can you see that in this lesion, again this lesion is hypoechoic, solid. Can you see this multiple microcalcification? So this feature is just like papillary CA, but this on FNA it turned out to be medullary CA. यहाँ पे मैं फिर से आपको वो बात दोहरा दूं कि रिपोर्ट के अंदर हमें ये नहीं लिखना होता है कि ये मेडुलरी सीए है या पेपिलरी सीए है। ऐसा भी हो सकता है कि आप पेपिलरी सीए दे वो मेडुलरी सीए आए, या वो आपने मेडुलरी सीए दिया वो पेपिलरी सीए आए। हमें इससे मतलब नहीं होता। We have to tell whether this is likely malignant or likely benign, and accordingly we have to give Thyroid's grading. तो ये जो लेक्चर्स है दैट इज मेलिग्नेंसी के, इसमें वी आर सीइंग रिट्रोस्पेक्टिवली कि हमने इसे टायराइड्स फाई दिया है, और on FNAC or on biopsy it turned out to be this. Okay, so this is how medullary CA looks like. Okay? Now again in case C you can see that there is a solid, some with few nodular mass lesion, and you can see that there are microcalcifications within the lesion which are showing posterior acoustic shadowing. So again, a very important feature is that this is taller than wider. Again, in this lesion, you can see this is taller than wider. So when you speak of a taller than wider lesion, this is a very microcalcification. Of course, this goes for Thyroid's 5, and on FNA this turned out to be a medullary carcinoma of thyroid. Okay, बात समझ में आ गई? So हमने क्या क्या देख लिया? हमने follicular CA देख लिया previous session में, papillary CA देख लिया, we have seen with medullary CA. Now the next important carcinoma which we are going to speak about is the anaplastic CA. So next is anaplastic CA. So when you speak of anaplastic, नाम में है anaplastic, so it has to be a very large mass. Again, this is hypoechoic, it is solid. This does not necessarily show microcalcification, very important. Anaplastic shows macrocalcification, very important point. Anaplastic shows macrocalcification, and it shows encroachment in the surrounding structures. Now, a very important feature which I would like to tell you is that anaplastic is having the worst prognosis. Anaplastic has the worst prognosis. So, these were few important features which differentiates it from the other tumor. Now let us come to the image so that it becomes easy to understand. So here, can you see this? Let us see the image. So you are able to see a well-defined hypoechoic lobulated mass lesion, okay, with which in the right lobe of thyroid, and you see that it is having extra thyroid capsular extension, okay, and it is almost pushing the carotid and IJV laterally. You can see them. Now, moreover, if you look inside, can you see that there are few cystic areas and there are areas of calcification which is showing posterior acoustic shadowing. Okay, so you are able to see that this is solid, hypoechoic, and you can see that there are macro calcifications. So whenever you have this, these are features of anaplastic CA. Of course, this would go with Thyroid's 5 because of its size, its solid component, echogenic areas within. Okay. Now again, this is another case where you are able to see that this is the lesion which has. Now what is the important feature here in this is that there is a lesion which is entirely replacing the right lobe of thyroid, which is showing heterogeneous appearance. So it is heterogeneous. You can say some areas are hyper, some areas are hypo. So this is a heterogeneous. Few cystic areas are also seen within it. Okay. And very important is that it is encasing common carotid. Can you see that? Common carotid comes within the substance. इसे कहते हैं encasement. Encasement यानी कोई vessel है, चारों तरफ से it is surrounded by the tumor or the lesion. This is called encasement. Okay. जैसे कि फॉर एग्जाम्पल यहाँ पे कैरोटिड आर्टरी है और यहाँ से लीशन ग्रो करेगा और पूरा इसको सराउंड कर लेगा. दिस इज कॉल्ड एनकेसमेंट. Encasement is a very important feature of malignant lesions. Okay, always remember encasement, or always remember to look for encasement. That is also important when the surgery is planned, because they will have to dissect out carotid if there is encasement. Okay, now let us come to there are of course macro calcification within the lesion, and IJV is pushed, but it is the lesion is in contact with IJV also. Now let us come to the case C. In case C, again you are able to see a heterogeneously hypoechoic lobulated mass lesion with extracapsular extension. Yeah, there is extracapsular extension, and you can clearly see that there is invasion into IJV. Look here. So there is thrombus within IJV. This is tumor thrombus. So this is vascular invasion. So whenever the lesion is invading vessels, always you should think of anaplastic neoplasm. Now here I want you to remember follicular CA. How was the spread of follicular CA? That is via blood. Okay, the route of spread is via blood. Similarly, in case of anaplastic CA, you can have involvement of the blood vessel. You can have tumor thrombus. Okay, so this was about anaplastic CA. So here we finish all four important forms of main thyroid neoplasm, which is follicular, papillary, anaplastic, medullary. If I want you all to remember, the most important features are follicular, they can be hyperechoic. Remember, so don't. Sometimes you might confuse it with benign nodule. So follicular, it can be hyperechoic. Remember one statement about it. Papillary CA, the statement which I want you to remember about papillary CA is that they can have microcalcifications and they are hypoechoic. And METs is via lymph nodes. Simple. About third, that is when it comes to medullary CA, it is associated with MEN syndrome. Remember. And the last important we saw anaplastic is that it's hypoechoic, it can show angioinvasion, and most important feature, it can show macrocalcification. So these are all important features of thyroid neoplasm. Now the last we'll be speaking about is lymphoma of thyroid gland. Although rare but not uncommon, we sometimes see cases of thyroid lymphoma. And what is the risk factor for thyroid lymphoma? Remember Hashimoto's disease. Hashimoto's thyroiditis is an important risk which can ultimately lead to thyroid lymphoma. So you see that nowadays the cases of Hashimoto's thyroiditis are rising, and with this in future you can see that in future the cases of thyroid lymphoma might also rise, might be on peak. Okay. Now here you see important features. You see that there is a rapidly growing thyroid mass, and this is large hypoechoic with diffuse enlargement of the gland. Okay, and you will see that it's a solid mass. Mostly it's of non-Hodgkin's type. So what is the most common lymphoma which is seen in thyroid gland? So diffuse large B cell lymphoma. is the most common lymphoma which is seen with thyroid gland. Okay. Now let us see the imaging appearance of thyroid lymphoma. So here can you see that the entire gland is enlarged, solid, heterogeneously hypoechoic. Okay. So in these cases, you should suspect that there is lymphoma transformation of the thyroid gland. One more important feature is rapidly growing mass. तो बहुत important history है कि आप पूछेंगे कि ये swelling कितनी दिनों में या कितने महीनों में बड़ी हो गई. If it is there is a rapid growth, always think of thyroid lymphoma. Okay. Now coming to also history of Hashimoto is important when it comes to this type of lesion. Another important image where you can see that there is a well-defined hypoechoic, large, solid, very hypoechoic mass lesion. You are not able to see many calcifications or anything, but you can see that trachea is deviated to one side, and this is what lymphoma of thyroid gland looks like. On CT scan, you see that there is a solid, this is a CT image and you are able to see that there is a solid hypo enhancing. This is not that enhancing, and you see a hypo dense mass on CT scan which can be seen here very clearly involving left lobe of thyroid, and here that this is the normal right lobe. Okay. So this is how lymphoma of thyroid gland looks like. Okay. Along with that, if it is lymphoma, you can see other lymph nodes in the neck or in mediastinum. So always you have to evaluate further, that is neck region and the mediastinum, whenever it comes to evaluation of lymphoma. Okay. Now this is a table which I have tried to summarize the important findings of benign lesion, intermediate lesion and malignant lesions, okay, which has to be seen. सो अभी इंटरमीडिएट के ऊपर इतना ध्यान नहीं देना है, हम उसे आखिरी में पढ़ेंगे, बट मोस्ट इंपॉर्टेंट ध्यान होना चाहिए हमारा बिनाइन की तरफ कि व्हाट इंडिकेट्स दैट द लीजन इज बिनाइन एंड व्हाट इंडिकेट्स दैट द लीजन इज मैलिग्नेंट. ओके, so let us see and let us remember it via illustration so things become easy. Benign will be simple cyst, so remember simple cyst, cysts are benign, or spongy. So if it is cyst, if it has got spongy appearance, that is spongiform, again it favors its benign. Cystic component, so if it is major cystic with chota, small solid, that again favors more the cystic component, more it is benign. Less the cystic component, less chances of benign. Okay. Very important is crystals and comet tail artifacts. If you see comet tail artifacts, that favors benign lesion. So very important, cystic component, spongiform lesion, comet tail artifacts. These three favors benign. Okay. Now after this we'll see all features of malignant lesions. So when it comes to malignant, solid, very important feature. So if the lesion is completely solid, if it is hypoechoic, very important. If it has microcalcification, very important. Lobulated margin, wider than taller, sorry, taller than wider, and microcalcification, interrupted peripheral calcification. What do you mean by interrupted peripheral calcification? That is, suppose this is a lesion and suppose there is a calcification, ring like calcification like this, and it is interrupted in between, and you see that the mass is growing like this from here, then this is a sign of malignancy. Vascular invasion, extracapsular spread, which we have seen, and malignant appearing nodules. All these are important for malignancy features. Now, in between features, intermediate features, solid hyperechoic or solid isoechoic, presence of hypoechoic halo, and dense peripheral calcification or macrocalcification. So these are signs of intermediate lesion. So you cannot tell benign versus malignant with more surety in these cases. Here FNAC is always indicated. Of course, So you have to look for all those malignant features to rule out malignancies. Also look for lymph nodal metastasis and other organ involvement. Okay. Hope this clears up features of follicular, papillary, anaplastic neoplasms of thyroid, and also about thyroid gland lymphoma. Hashimoto is a very important risk factor for thyroid lymphoma, which you must always remember. And with this, I would end this session here. I also would request you to give your feedbacks and comments in the chat boxes below.